Hi guys, so now we're going to talk about communication. And communication is the essential part of our job that we do. We communicate with other healthcare workers, we communicate with patients, we communicate with families, we communicate with the public. And so it is essential that nurses have excellent communication skills in order to provide safe, quality, and effective patient care within our selected environment. So we know that there's a communication process. So there's the referent. This is the event or the thought which initiates the communication. So certain events, let's say for example, patient comes to the hospital, patient is having pain. So that causes the need to have communication occur. There's the sender, and that's the person who initiates or encodes the communication. So they're the person who's trying to send the message about their thoughts or their feelings to a person who's going to receive that information. And that person is the receiver. And so that person's job is to decode or interpret what it is the sender has sent them. And this can occur where a lot of miscommunication occurs is between the route between the sender and the receiver. So as the receiver, we need to be actively listening. We need to observe and engage in conversation to clarify or get questions answered so that we properly decode the message that's being sent to us. So there are factors that affect the ability to receive a message accurately. It could be that the timing, it could be culturally based, there could be emotional or physical stresses that are happening, and so these can lead to misdecoding of the information. So then there's the message, and that's the actual information that's being communicated. There's the channel, which is the method, and then there's the feedback, and that's the response that the receiver gives. So this is the communication process. This is just a picture, and I'm not going to explain each part of it. So here's a quick quiz. So when you get a moment, do the matching. They don't read referent right across and say it's the one who encodes or decodes the message. You need to communicate, match these. So to what they need to be matched to. So there are modes of communication. We have verbal and nonverbal modes of communication. So we know that our verbal is how we speak, what we say, and what we write. And then we have our nonverbal communication, which is our body language, which can be communicated by gestures, eye contact, eye movement. We need to understand that most of our communication is considered to be nonverbal in the communication component. And we believe that in studies, our nonverbal communication is the more accurate mode of conveying information. And as nurses, we need to both make sure that our nonverbal and verbal communication is consistent, and we need to watch our patients for inconsistencies in these two areas of communication. So nonverbal communication is the wordless transmission of information, and body language constitute about 55% of nonverbal communication, where our voice inflection can be the other part. So body language may be our posture, our facial expressions, touch, gestures, that we need to be sure that we observe not only ourselves but patients and families for nonverbal cues when we're talking with them. We also know that a way a person stands or sits can convey volumes to us. We know that there are what we call threatening postures, open postures, and so we look for those when we're communicating things to patients. We know that the use of making physical contact with our patients can communicate caring, or it can be perceived as restrictive, and that depends on what type of touch is used. And this is especially true if we have patients who are in painful or stressful procedures. The use of gestures is challenging for the nursing because of multicultural environments. Gestures must be effective, Gestures may be most effective when used with people who have limited senses. There's a symbolic expression through touch, through the use of makeup, jewelry, and clothing that can communicate things to us as individuals, what people wear, how they present themselves. And that's why as nurses we need to take pride in our professional appearance, and we try to be consistent with jewelry, nail polish, and those types of things because of what we're trying to communicate a professional person. We have to recognize that we have voice inflection, which is the second most significant form of nonverbal communication. So we need to be aware of our tone, volume, rhythm, and the rate at which we speak. We also must be active listeners in perceiving these things as well during interactions with patients, families, and healthcare providers. So it can also provide insight into the significance of the information being shared. We also need to recognize that there are zones of interaction. And this is Edward Hall, who developed this of spiritual requirements for humans and animals. He defined 4 specific distances in which people interact. And nurses interact with patients within each of these distances. However, as nurses, we must become more comfortable at interacting with people in their intimate and personal space while providing direct patient care. And we need to respect and honor the fact that we've been invited to be part of that space, for which if we were not providing patient care, we would not be invited into that intimate or even personal space of an individual. We need to be careful, watch our verbal communication. This is where we look at the setting, context, and content. This is where we want to know what needs to be communicated, and it needs to be monitored carefully so we avoid misinterpretation or errors. Both, this would be, let's say, when we're receiving an order from a physician, we want to be sure we're actively listening, we're writing down what we hear, and then we're restating it back to make sure we have heard the person correctly, and that we allow time for feedback and correction if we have inaccurately or accurately heard the information. A lot of mistakes are made because this loop of listen, write, repeat has not been followed by some nurses. They think they can remember what they've heard. They don't repeat back what they've heard for clarification to make sure they're right, and mistakes happen. But there's also written communication. Written communication can be misunderstood sometimes or misinterpreted. We don't get the voice inflection or the voice component when we use written, or the nonverbal is often not there. We can't often convey a sense of urgency through written communication except by our word choice. So we have to make sure that anytime we're using written communication as well, that we remember and maintain confidentiality. And electronic communication as well, we need to be sure we're remembering confidentiality, and we need to always be aware that there's the possibility of miscommunication. There are diversity issues. We want to look at the lifespan and know where our patient is, or the people we're working with are within that lifespan, because we know each generation has its own diverse considerations. We also want to look at gender. Gender can affect whether we do or don't make eye contact. It can help us understand whether or not we're going to have people of the opposite gender care for people that are not their gender, and we need to be respectful of this. And we also need to look at culture and ethnicity, because each culture has their own values as to who and when can enter certain spatial domains, such as personal space. We want to remember that in intrapersonal communication, this is the communication we give to ourselves. Each person communicates with self-talk, whether it's the patient, the nurse, or members of the healthcare team. So we know that we can have positive self-talk. That's where we build our own personal self-esteem and our self-confidence. This is where we tell ourselves good things. We empower ourselves with positive things. We also know that there's negative self-talk. That's where we tell ourselves negative things. Patients may be telling themselves negative things, and this creates difficulties in getting people to have positive thoughts of their health care. Then they may be resistive to the treatment that we want because they're telling themselves a lot of negative self-talk. It can impact how we treat their pain and anxiety. It may make those worse. We might see patients with self-talk who participate in meditation or prayer, and we need to allow for opportunities to do this. There's the interpersonal communication, which occurs between at least two individuals or more. And we do know that a great deal of medical errors involve issues related to interpersonal communication. So we need to be sure that we know that we're collaborative and that we work as an interdisciplinary team, and that's essential for patient safety. So we do not just, it's not just us and our patient. We have to recognize that it is us and the whole healthcare team providing safe, quality, effective patient care. There's also interprofessionalism communication, and that's where we're professional with our communication with our team members so that we create a culture of safety, and that patient safety is the number one priority. And we also have to remember that there are ethical implications, and we have to remember that there are role boundaries or limits and responsibilities of individuals in given settings. So when undertaken by nurses, actions of such as sharing personal phone numbers or with patients or agreeing to meet patients outside the healthcare setting is not appropriate because we violated the nurse-patient boundaries. We also need to remember that ethical and legal action have been taken against nurses or healthcare professionals who ignore their professional role boundaries. There are also ethical and legal professional things within our practice that we want to look at. One of the things that we're going to talk about and we're going to practice is SBAR communication. And that's where we have this SBAR synonym. This is where we talk about situation, background, assessment, and recommendation. So the situation is what is happening right now, what is currently going on, what is the event that's initiating the need for communication. Then we give some background, what has led up to the current situation. We want to give an assessment that is identified. What is the identified problem? What is the assessment around that identified problem, which has led us to believe that that is the problem? Are there any concerns? Are there any needs? And then we might make a recommendation, like what action or interventions would we like to see initiated to alleviate the problem. Nurses use SBAR when communicating with doctors and other members of the healthcare team. It provides a organized and concise way in which to communicate information. We want to know that it's our responsibility to establish and maintain professional role boundaries when interacting with patients. That's what we just talked about a little bit ago. There's also small group communications, and this is where small group dynamics come in. That small group could be you and the members of your nursing staff that are on for the day. It may be the members of the nursing staff for your shift. It might be the members of the nursing staff for your unit. That small group could be the patient and their family. It could be a multidisciplinary healthcare team. And so we need to use effective communication in these particular environments as well. So then we move on to the nurse-patient relationship. So there are 5 focus areas within the nurse-patient relationship, and we want to build trust. We want to demonstrate empathy. We want to be sure we understand the boundaries, and we want to make sure that there's a comprehensive plan of care for the patient. And all of these come and go, but they all are essential in developing the nurse-patient relationship, and we cannot ignore any one of them. We also know that there are phases of the nurse-patient relationship. There's the orientation or introductory phase, and this occurs at different times and throughout the patient interaction with healthcare team members. There's also the working phase in which we're developing a helping relationship. We have goals, outcomes, and we're working towards and collaborating to see that the goals are met. And then we have a termination phase, and this is when it's ending, the relationship is ending. This can occur at the end of your shift. This can occur at discharge. This can occur at various stages within the patient-nurse relationship. And we just need to recognize that we will be going through these stages as we work with our patients in relationship, in a nurse-patient relationship. And then these are some nursing diagnoses that you could use for communication, whether altered or effective. And so there are some factors that can affect the timing of patient communication. So we know that if patients are in pain or anxious, we need to address that issue before we start communication with them. But we want to be sure if we notice anxiety or they're having pain, that we are brief. We're using short sentences and we're specific. And then we want to be sure that we educate patients if they're coming in for surgery, not right the moment before they're going in for surgery, perhaps at an earlier time or a different time. We want to be aware of the location and the amount of distractions that may come into play, not only for confidentiality, but we know that distractions impede learning. We also want to be sure that our patients are alert and oriented before we delve into things that are essential for their care. It's awfully hard to get a good health history when patients are under the influence of narcotics. We may need to come back and revalidate the information that we've had. We want to be sure that we show respect not only for the patient but their family, and we'll communicate that as a nurse both verbally and non-verbally. We might ask the patient what name they prefer to be called while they're in the hospital. We want to be sure that the healthcare information is protected, and we want to be sure that we're fostering autonomy and decision making of the nursing actions. We want to be sure as nurses that we have good facial expressions that control our body language even when we're having challenging interactions. We want to, there's assertiveness. It's the ability to express ideas and concerns clearly while respecting the rights and thoughts of others. So, we want to know that when we communicate with patients and family members, we're doing this regularly and without hesitation. We're not avoiding communication. We want to demonstrate confidence, and we want to make sure that we're showing respect not only for the patients, but our colleagues. However, we need to remember that if we're overly assertive, it may be mimicked with aggressive, and it may make the patient or your coworkers feel like you don't respect their rights or their opinions. And we know that nurses who communicate aggressively tend to receive negative or defensive responses, not only from patients and family members, but from other members of the healthcare team, and this can impede the process of providing quality, safe patient care. We want to remember that collaboration is essential and that we need to gather healthcare information and provide a comprehensive patient care. We need to know that patients may require collaboration from different healthcare professions and different healthcare disciplines while they're in the hospital or in the outpatient setting. And often the nurse may be the person who's placed to coordinate these. We might be the key, the contact key, and be able to expedite how these occur. And we want to be sure that we're respectful and recognize that there's of the time and the resources and their limitations. We want to make sure that we have ongoing communication with the patient and the healthcare team so that adjustments in the healthcare plan can occur. We know that within communication there is delegation, and this is a multifaceted responsibility of the nurse. So when we're communicating delegation, we must be collegial and we must respect all members of the healthcare team. It is important to call these other members of the healthcare team by their preferred names. And we need to be accurate with what we're communicating because that ensures positive patient outcome. We need to be able to receive feedback from the person whom the care is delegated to so that they can clarify and understand what it is exactly you have delegated to them, and this will increase the accuracy. We also are responsible for patient advocacy. This is one of the things that is very essential to the nursing profession, and so this means we're going to advocate for the rights of others, especially those who are vulnerable or unable to make their own decisions independently. And we must be able to effectively advocate for patients, so therefore we must be knowledgeable and organized to be able to communicate in a caring manner. So we're going to talk about social, therapeutic, and non-therapeutic communication. Patients perceive nurses who develop strong therapeutic communication as caring and professional and compassionate. These nurses who understand the impact of effective communication to the patient are less likely to engage in what we call social conversations with patients and coworkers when it is not appropriate to do so. Social communications most often occurs among individuals who know each other or who are getting to know each other. It typically involves sharing ideas, giving advice, verbalizing opinions, and making judgments. And so as nurses, we want to avoid this when it is not appropriate for us to do so within the context of the current situation we're in with our patient. We want to make sure that we have a consistent use of therapeutic communication, and when we do, we want to demonstrate empathy and concern for our patients. There are various techniques that can assist a nurse in gathering and verifying and validating assessment data. If you take a look on table 3.2, these are some examples and some rationales for some verbal therapeutic communication techniques, and you should practice these not only with your fellow students, but with each other, with your families. So this is a quick quiz. Answer this when you get a moment. So within therapeutic communication, there is a mnemonic that's called the SOLAR. So SOLAR means that we're going to engage as the listener to sit, if possible, facing the patient. We want to remind the nurse to maintain an open stance, that's what the O, or an open posture, that shows welcomingness while we're listening. We want to lean in, which is the L, towards the person who's speaking, while maintaining this open stance. We want to maintain eye contact without staring or making the other person uncomfortable. And the R is to tell us to relax, and we want to demonstrate relaxation within the conversation that we're having. We want to be sure that when we rephrase something, we do so within a positive manner. Additionally, we want to make sure that we use techniques that promote cooperation and affirmation. Here's an example of a negative and positive focus in asking a patient to use their incentive spirometer. We want to remember that positive language will motivate individuals to comply with the activities or healthcare plan that we have worked out with them. We want to remember that there is non-therapeutic communication, and this can be hurtful or potentially damaging to an interaction. We want to remember that we want to limit our social conversations when we're interacting with patients. We want most social conversations are considered to be non-therapeutic, mostly because they can shift the conversation away from the patient's needs, perhaps to the nurse's needs. And so we want to remember that the patient comes first in the communication cycle. We want to recognize that people have defense mechanisms, and that these defense mechanisms are often protective, and they can be used for short or long-term periods, while others may be, when used consistently, are harmful. It is helpful if we understand and can identify defense mechanisms such as denial, and there are other ones such as compensation, which may positively influence the productivity of a person's life. We have to understand that when patients are faced with situations perceived as hopeless, they may exhibit anger towards the nurse. When this happens, it is important for the nurse to recognize that this is displacement and to address the real concern of the patient rather than taking the patient's expression of anger personally. The nurse should also document the use of defensive mechanisms in the patient chart so that others can see, and that if there is a consistent unhealthy use of defense mechanisms over extended periods of time, we may need to refer the patient for professional help beyond what we can provide as the nurse. So these are some examples of some different types of defense mechanisms. So this is another quick quiz. So just kind of answer that for yourself to make sure you're paying attention through the lecture. So there are some special considerations We need to understand that patients have sensory impairments that may make nonverbal or verbal communication both difficult or impossible. We need to recognize that communication with sensory impaired patients require creative and we need an adaptation to ensure the patient's needs are met. So we want to recognize that patients with these types of sensory impairments may feel isolated or frustrated because they feel like they're not being communicated with. So we need to be sure that we do find creative ways to communicate with these people that both identify the potential strengths and obstacles that are available to promote the most effective communication. There are various approaches that may be effective in providing patient care with those who have impaired hearing. Often patients may wear hearing aids. If they do, we should encourage them to do so, and we should make sure that their batteries are working. And it's also good as a nurse on admission, maybe perhaps to see when the last time they went to see a hearing specialist. We want to understand that often people will take their hearing aids out because it hears way more than they want to. We want to make sure that we're raising our voice slightly, but we're not over raising our voice and yelling at the patient. We want to make sure that there's adequate lighting because maybe they can see our face and interpret our nonverbal communication. Standing 3 to 6 feet away and making eye contact can help when we're talking to people who are hearing impaired. We want to make sure that we validate that they've heard what it is that we've asked. In patients who are deaf, we need to make sure that there's adequate lighting and avoid over enunciation or speaking slowly while in direct proximity to deaf patients. Adequate lighting, avoiding over enunciation, but we do want to speak slowly within direct proximity because maybe they can read our lips or they can perceive the meaning of the gestures or facial expressions. If patients use sign language as a primary means of conversing, we should get an interpreter to help. We do ask that we generally not use family members to be the interpreter. Most hospitals have institutional interpreters which can be called in to help with the interpretation. So we want to remember that there always is collaboration and delegation, and we want to be sure that we get the right interpreter for the deaf person or even the person who has limited English proficiency. So at St. Joseph's, I'll give you an example. We have a phone that we can bring to someone who speaks of a different language, and we can connect them with an interpreter that can help them understand in their language. We do have approved individuals that come in for patients who are sign language only, and we generally do not use family members as the interpreter for the information. They may be present to hear the information, but not be the interpreter responsible for communicating the medical or healthcare information that needs to be communicated to the patient. We have visually impaired patients, so we need to remember that they may be visually impaired or completely blind. We want to be sure that we communicate with them and that we are anticipatory. It means when we walk in the room, we let them know we've walked into the room. We want to be sure that we remove any potential hazards, and we want to be sure we locate verbally for them where things are located. For example, if we're putting things on their bedside table, we can use a clock, and we might tell them that something is positioned at 2 o'clock, 3 o'clock, 4 o'clock, and that helps them get an idea of where to put their hands. Some may be able to see large print. Some might be able to do braille. There might be audio or ebooks, which might help with communication. There are physically or cognitively impaired patients. Again, we want to make sure that we find a way to communicate with them. If they're dysphagia, then we want to be sure we allow plenty of time for that patient to express their needs. We might want to use sign boards or word boards or letter boards or picture boards in order for them to be able to communicate back with us. We might need to remember that we need to use simple, small words and phrases. For those who are quadriplegic or intellectual disabilities, we want to be sure, say they have a tracheostomy tube or on a ventilator, they can write, they can use their eyes. They might be able to use electronic transducers to connect remotely to things so that they can communicate. We just want to find the best way for them to communicate with us, and even if they're intellectually disabled. We want to be sure that we're communicating with families and within our community as well, and make sure that that communication is, because we're a discipline, nursing addresses the effect of illnesses on patients, but rather simply the illness itself. We want to maintain viable lines of communication among patients and their families, and even their friends is critical. We want to be particularly helpful. Our therapeutic techniques, which may show into the existence and strength of available support systems. We know that family dynamics are often revealed by listening and observing family. We can get a little bit of a picture of the impact of illness or associated circumstances. We want to be sure we do some assessment about the patient's family or social support system in which the patient will be discharged to or they engage in, which can help us be more effective in making sure that communication loop is closed and the patient finds the resources they need to have successful health promotion. Thank you.